Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. We are from Group 1 and today we are going to present our CPL case, which is unknown substance poisoning. My name is Muhammad Aif Hafizin, 1912609. And these are my group members, Fitria, Irina, Batrisha, and also Anis Farhana. Okay, first moving on to the patient, which is the case. The history or the case given is a 29-year-old comatose male arrived at your ED via ambulance after having two seizures at home. The paramedics state that en route to the hospital, he had a generalized tonic-clonic seizure that lasted 25 seconds. According to family members, he has no prior history of seizures. Patient was reported to have suicide attempt, tried to cut wrist 4 days ago, but the medication taken was unknown. Based on the vital signs reported, the temperature of this patient was high, which is 38.3, higher than the normal range. Heart rate also higher than normal range, which was 140 beats per minute. Respiratory rate also higher than the normal range, which was 22 breath per minute. And the blood pressure also was high than the normal range, which was 180/99 millimeter mercury. Based on the systems, this patient generally is in the coma condition, and his pupils are 6 millimeter bilaterally and sluggishly reactive to light. But there is no scleral edema or hemorrhage. But this patient has no gag reflex, or the gag reflex is absent. The pulmonary is clear to auscultation bilaterally. And for cardiovascular, he has regular rhythm, but is tachycardic, and the cardiac monitor shows that this patient is having sinus tachycardia. Based on abdomen examination, this patient has hypoactive bowel sounds, and he has palpable bladder. Okay, based on the case, the immediate diagnostic and therapeutic measures that we should take is as here. First and foremost, in any emergency cases, we need to do triage assessment. Okay, based on this patient condition, this patient presented to ED in a comatose condition. As we know, comatose patient will usually lose their airway protective reflexes and also respiratory drive. This also patient also developed a generalized tonic-clonic seizure en route to the hospital that lasted for 25 seconds. If this seizure is not treated quickly, it will cause pulmonary aspiration, hypoxia, and also brain damage to this patient. Review of the systems also revealed that this patient has no gag reflex. Absence of gag reflex may suggest brain death in the comatose patient, and also can increase the risk of aspiration pneumonia. So based on this patient condition, comatose, this patient developed generalized tonic-clonic seizure and also has no gag reflex. This patient condition can be categorized as severe. So, as this patient condition is severe, the immediate diagnostic and therapeutic measures that we should take are as below. First one, the goals of immediate treatment are to stabilize the patient in the severe condition. This will include first, airway, management of airway, breathing, maintaining circulation, also administering dextrose, ABCD in the short form. So since the patient is comatose and had no gag reflex, so this patient should be immediately intubated by using endotracheal or nasotracheal route to secure and protect his airway. Next, this patient should be assessed about the breathing status by measuring the arterial blood gases. If this patient has hypoxemia or hypercapnia or showing any sign of hypoxemia and hypercapnia, he should be on mechanical ventilator as a support. Next, patient circulation also should be assessed by using continuous monitoring of pulse rate, urinary output, and also peripheral perfusion. Then, since this patient is coma or having altered mental status, this patient should be given concentrated dextrose, 25 gram, equivalent to 50 milliliter of 50% dextrose solution via intravenous intravenous. Okay. Next, if the patients develop another fitting episode, he should be given IV benzodiazepines or IV barbiturates such as diazepam, lorazepam, or phenobarbital. The dose are shown in the slide. After that, if the patient is stabilized based on the therapeutic measures discussed before, more detailed evaluation could be made to confirm the diagnosis of this patient, which includes performing a toxicologically oriented physical examination. Okay, based on all of the signs and symptoms reported in this patient, such as this patient is having sinus tachycardia, having high blood pressure. This patient also has high body temperature, or known as hyperthermia, and his pupils are also dilated. Because normal pupil size in the presence of light is 2 to 4 millimeter, but this patient pupils diameter are 6 millimeter, which is slightly dilated. And also, this patient also has palpable bladder, showing that he may has urinary retention, and also the bowel sounds are also absent, meaning that anticholinergic system are dominating at that time. So based on all of the signs and symptoms reported, this patient may have anticholinergic toxidromes. We can see on the picture at the left side, the visualization of anticholinergic toxidrome, same as what this patient are having. Okay. After that, other diagnostic and therapeutic measures that can be taken into action for these patients include finger stick glucose. This is to rule out hypoglycemia that cause alteration in mental status in this patient. And also we can do acetaminophen and also salicylate levels to rule out common co-ingestions of these agents. And also we can do ECG, electrocardiogram, to rule out conduction system poisoning that affects the QRS and QTC intervals. Besides, urinalysis and serum creatinine kinase level can be checked to rule out rhabdomyolysis, as we know that this patient developed generalized tonic-clonic seizure that lasted 25 seconds en route to the hospital. Next, activated charcoal may be given to this patient if the airway is already intubated and protected. It is important to be noted that intubation should not solely done for administering activated charcoal. Okay, last but not least, evaporative cooling or antipyretic can be given for this patient to manage his hyperthermia. So I think that's all for the first part. I'll pass to the next presenter to present the second part. Thank you.
I'm Patricia Balkis, will present the differential diagnosis in this case. So as mentioned by Brother Naif, this patient most probably has the anticholinergic toxidrome. So therefore, this is the list of differential diagnosis from most likely to the less likely according to this case. So firstly, alcohol and sedative hypnotic withdrawal. So sedative hypnotic withdrawal syndrome is categorized by the symptom that's similar to the alcohol withdrawal and include the symptoms such as autonomic hyperactivity and psychomotor agitation. So the autonomic hyperactivity is a life-threatening manifestation that affect the central and peripheral nervous system like hypertension, tachycardia, and hyperthermia. So psychomotor agitation can cause a variety of signs, including restlessness, inability to sit still, dashing around without purposeful movement, and tapping. So this diagnosis is more likely to resemble the patient's symptom, which are fever, fast breathing, seizure, increased heart rate, and high blood pressure. So some of the symptoms that listed in this table are experienced by this patient in this case. Next, the neuroleptic malignant syndrome. So it is often present with the muscle rigidity, high fever, changes in the mental status, and autonomic instability. So the autonomic nervous system regulates the certain body process such as the blood pressure and rate of breathing. So therefore, the impairment of this system leads to the wide swing in the blood pressure, fast or abnormal heartbeat, and quick breathing, excessive sweating, and excessive secretion of saliva. So the anticholinergic toxicity and neuroleptic malignant syndrome can share the symptom of fever, tachycardia, tachypnea, and potentially decreased bowel sound, which present in this patient case. So some of these symptoms are experienced by this patient in this case. Then we go to the less likely diagnosis for this case, which is viral encephalitis. So it typically begins with a fever and headache. So the symptom rapidly worsen and they may be a seizure, confusion, drowsiness, loss of consciousness, and even coma. Include a problem with the movement like a muscle weakness, stiff neck, joint pain, or with a sense such as sight or hearing. So it affects the cognitive functioning, leading to the confusions and behavior changes. So this diagnosis can be excluded as it did not involve with any cardiovascular status like high BP or heart rate, and also did not involve a gastrointestinal system like bowel sound. Next, the head trauma. So this is the table of the common symptom of mild and moderate to severe head injury. So traumatic brain injury can have the wide-ranging physical and psychological effect. So it can include any of the sign symptom of mild injury as well as this symptom appear within the first hours to day after a head injury. So the symptom may include the loss of consciousness, seizure, balance or coordination problem, serious disorientation, and inability to focus the eye, loss of the muscle control, or worsening headache and coma. Again, this diagnosis can be excluded as it did not involve any cardiovascular status like high BP or heart rate, and also did not involve gastrointestinal system like bowel sound. Next, the Reye syndrome. So it is a very rare disorder that can cause serious liver and brain damage. The Reye syndrome mainly affect the children and young adult under 20 years old. So from this statement, this diagnosis will be less likely to be differential diagnosis for this patient as this patient is an older adult with the age of 29. Plus, there is no problem with his liver condition. So the severity of the Reye syndrome can be classified with the clinical staging system as we can see in this table. So it can be concluded that this diagnosis can be excluded from this case. Next, the postictal state is the recovery period following a seizure where the patient may experience the cognitive deficit, behavior changes, and psychiatric symptoms. And it also categorized by disorienting symptoms such as confusion, drowsiness, hypertension, and headache. The postictal state shows a rich phenomenology of neurological deficit and psychiatric symptom. So this diagnosis may be less likely to happen as no neurological impairment or psychiatric has been mentioned in this case. And most of the symptoms mentioned in this table do not occur in this patient. Lastly, acute psychotic disorder. It is a transient disorder with the onset of one or more of the following psychotic symptoms. So the main symptoms are hallucination, delusion, and disorganized thought and behavior. Hallucination are where someone see, hear, smell, taste, or feel things that do not exist outside their mind. A delusion is where a person has a false belief in something untrue. So people with a psychosis sometimes has a disturbed, confused, and disrupted pattern of thought. And all these symptoms are absent in this patient, in which in this case, this diagnosis can be excluded. That's all from me. Thank you.
Assalamualaikum, my name is Nur Irina and I'll continue with the consideration of sustained injustice. Firstly, based on the signs and symptoms, it is further confirmed that patient is having anticholinergic toxicity. However, the suspected medication is yet to be confirmed. There are quite a few medications that exhibit anticholinergic toxicity. The first one is antihistamine toxicity. The toxicity associated with antihistamine is also quite common. The agents include diphenhydramine, chlorpheniramine, promethazine. Toxicity involving antihistamine usually occur when ingested 3 to 5 times more than usual daily dose. Among the agents, sedating antihistamine like diphenhydramine is reported to be very prevalent in intentional injections. Based on a study, it accounts for 71.1% of deaths involving antihistamine overdose. Ingestion of more than 1 gram of diphenhydramine can lead to delirium, psychosis, coma, and death. Based on the signs and symptoms that patient develop, there is one clinical feature that can help us to consider the substance that patient may ingest it, which is sinus tachycardia. Prominent sinus tachycardia with drug toxicity is usually associated to the first generation antihistamine and also tricyclic antidepressant. Since antihistamine is an OTC drug, it is more accessible to the patient. Therefore, we suggest that the patient has ingested sedative antihistamine. Next, we also consider tricyclic antidepressants. The agents are commonly amitriptyline, clomipramine, nortriptyline, trimipramine, and also imipramine. This is because from previous medical history, it is stated that patient attempted suicide several days before. This may suggest that patient may struggle mentally and also been prescribed with tricyclic antidepressant. TCA have a narrow therapeutic window, which means it can be fatal relatively at lower doses. However, in serious toxicity of TCA, an overdose patient will develop hypotension due to alpha-adrenergic blockage. This condition is contradictory to our patient as the patient developed hypertension instead. Therefore, we did not consider tricyclic antidepressant injections. Lastly, there are also anticholinergic drugs that can be considered in our patient. The first one is antipsychotic toxicity. As previously mentioned, we assume that patient has mental disorder, for example, MDD. Hence, we can consider antipsychotic agents that are indicated for MDD as augmentation agent. These include olanzapine, quetiapine, and also aripiprazole. However, it is unlikely that patient ingested antipsychotic because usually these three agents will cause hypotension instead. Next, we have anti-Parkinson drugs. There are quite a number of anti-Parkinson drugs that exhibit anticholinergic activity. For example, we have benztropine, trihexyphenidyl, ofenadrine, procyclidine, and also piperidine. However, the injections of these drugs are very unlikely in this patient because the patient is way too young to have Parkinson's disease. Hence, anti-Parkinson can be omitted from the consideration. And lastly, we have anticonvulsant. For example, carbamazepine. As previously stated, patient had no prior history of seizures, and it is unlikely that patient was prescribed with anticonvulsant. That's all for the substance injections. I'll press to the next presenter. Thank you.
Bismillahirrahmanirrahim. I'm Nurul Fitra. I will continue with question number 4. The question is, what therapeutic trial you may have to confirm the diagnosis? Explain the mechanism of action. In patients where no history is available or when the exposure is unknown, anticholinergic poisoning should be considered in patients with altered mental status and physical examination findings consistent with anticholinergic poisoning. The first therapeutic trial that may have to confirm the diagnosis is administration of physostigmine. If a patient is administered an appropriate dose and rate of physostigmine and develops signs and symptoms of cholinergic excess such as bradycardia, sweating, diarrhea, urination, meiosis, bronchospasm, bronchuria, emesis, and lacrimation, the patient does not have anticholinergic poisoning. Before physostigmine is given, the patient should be placed on a cardiac monitor. Atropine and resuscitative equipment also should be available at the bedside. The recommended dose of physostigmine is 0.5 to 2 mg. The drug should be given by slow IV push, generally over 5 minutes. However, physostigmine should not be given if a condition other than a purely anticholinergic poisoning is suspected, for example, transcyclic antidepressant overdose. Other relative contraindications to physostigmine include reactive airway disease, intestinal obstruction, epilepsy, and cardiac conduction abnormalities. Next, moving on to the mechanism of action of physostigmine. Physostigmine is a carbamate acetylcholinesterase inhibitor that binds reversibly to inhibit acetylcholinesterase in both peripheral nervous system and central nervous system. Once physostigmine blocks acetylcholinesterase, the concentration of acetylcholine at muscarinic receptor will increase and overcome any anticholinergic blockage. Physostigmine is a tertiary amine and crosses the blood-brain barrier. Other medicinal carbamate are unable to transfer this barrier. Physostigmine is thus extremely useful in reversing the peripheral and central effect of anticholinergic toxicity. Apart from that, ECG also should be done to this patient to differentiate between purely anticholinergic poisoning with TCA poisoning. ECG finding with TCA poisoning include prolongation of the QRS interval and arrhythmia. ECG must be obtained approximately every hour. Besides, TCA level is also useful to confirm the diagnosis. Next, sodium bicarbonate also can be given to the patient if he had prolonged QRS interval and wide complex tachyarrhythmia related to anticholinergic poisoning. Sodium bicarbonate therapy is also indicated in patients with TCA poisoning who develop widening of the QRS interval greater than 100 milliseconds or a ventricular arrhythmia. The initial dose of hypertonic sodium bicarbonate is 1 to 2 milliequivalent per kilogram given as a rapid IV push through a large bore IV catheter. If there is no response to the initial dose, it may be repeated after 5 minutes. If the QRS narrow after bolus therapy, begin a continuous IV infusion of sodium bicarbonate. Administer a solution of 150 milliequivalent of sodium bicarbonate in 1 liter of 5% dextrose water infused at 250 ml per hour. Frequent ultra blood pH measurement measurement should be obtained during treatment with sodium bicarbonate to maintain pH of 7.5 to 7.55. That's all from me. I pass to the next presenter.
I am Anis Farhana Ramli. Next, we proceed with the next part, which is response to treatment and monitoring parameters. Since these patients' symptoms are due to anticholinergic toxicity and also patient is currently on comatose state, therefore our therapeutic goal for this patient is to stabilize patient's condition and also to reverse the effect of anticholinergic drug. So these are the monitoring parameters that should be done. First is oxygen saturation. So since patient is decided to be intubated, it is important to monitor patient's oxygen level to prevent further hypoxemia. This is because more serious complications may occur if patient having hypoxemia, and it may affect patient's other vital organ as well, such as brain and also heart. This could be done by monitoring patients' clinical marker of hypoxemia, for example, to monitor the presence of blue discoloration of the skin or tongue. And pulse oximetry can be used and must be monitored once in a while to ensure patients' oxygen saturation always above 95%. The next one is to monitor antidotal therapy effect. Apart from monitoring the positive response towards these antidotes, it is also important to monitor their adverse effect because lisostimine is a cholinergic drug, while sodium bicarbonate is an alkalinizing agent. So excess administration or overdose of this drug might lead to additional toxicity, which is a cholinergic crisis associated with lisostimine and metabolic alkalosis associated with sodium bicarbonate. So as for lisostimine, it should be accompanied with a close cardiac monitoring. And since lisostimine onset of actions are quite short, so it will take 3 to 6 minutes for the effect on CNS to be apparent. So it is expected for patient to be in response to lisostimine within minutes. As for sodium bicarbonate, our target is to reduce the increased blood pH within 7.5 to 7.55. It is reported a significant increase in blood pH occurs within 30 minutes after ingestion of extended dose. Peak blood pH occur within 60 to 90 minutes. So it is expected for patient to be in response to sodium bicarbonate effect within an hour after ingestion. And next is to monitor the ECG. This is to ensure patient's heart rhythm in control. This is also to avoid patients having cardiac arrest. And the last one is to monitor patients' vital signs. This is important because in the beginning, patients present with abnormal vital signs. So therefore, our goal is to monitor these vital signs so that it can return to its optimal level. That's all from us. Thank you very much.